So good afternoon, everyone. Welcome to the first session of the 2023 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester, and our co-sponsor is the Western New York Rural Area Health Education Center, which is also a HRSA-funded education center. We are pleased that you're all with us today. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. My co-host is Christine Chappell, and she is the administrative coordinator at the Western New York Rural Area Health Education Center. We are very glad you can join us for our fourth year hosting this series. So before we begin, just a couple housekeeping items. There are two very important buttons on your toolbar. We have the chat button, and that will allow you to type hello and introduce yourself with a name, job title, agency, location. We have people from across the country and the world joining us today. So welcome to folks from all across New York State, Oklahoma, Tennessee, and I believe we have one person from South Africa. So hello, Sylvia. Thanks for joining us. This is a meeting format, so we don't have a Q&A button, but we ask that if you have questions at any time, please put them in the chat and we will address them. It's up to our presenter today, whether we address them at the beginning or in the middle or the end or all of the above. But we will definitely leave time for questions at the end. So now let me walk you through our CME slides. So welcome to our presentation. We do have CME and social work continuing education credits for today's session. We have no financial relationships disclosed by either our planning committee or our presenter for today. For claiming your credit following the webinar, I will email you this link of how to claim your credits. I do ask that you give us at least 30 days before you log into the system to see if your credits are there, because it takes me a few minutes to, probably like an hour, to compile the attendance and then send it over to our CEL office, and then they upload it into the system. So just give us at least 30 days, but if you don't see them by April, definitely send me an email. And there was no commercial funding received to support this activity. As I said, both of our agencies are HRSA funded, and that is where our funding comes from for today. So now I'm going to stop sharing my slides and invite our presenter, Dr. Elmes, to please bring up your slides while I introduce you. So our featured speaker today is Dr. Abigail Elmes. She is a visiting clinical assistant professor at the University of Illinois at Chicago in the College of Pharmacy. She earned her doctorate of pharmacy from the University of Pittsburgh and completed residency training at Northeastern University in Boston and an academia and family medicine fellowship at the UIC College of Pharmacy. In addition to her teaching role, Abigail practices as a clinical pharmacist at the Community Outreach Intervention Project's mobile medical unit, providing substance use disorder and harm reduction care to vulnerable patient populations on the west side of Chicago via street medicine. Abigail has been leading the Safe Home program since 2020. We are very honored to have such a dedicated and knowledgeable scholar with us today. So now I will turn the program over to Dr. Elmes.
Thank you, everybody. If you would just want to give me a thumbs up that you can see my slides. Awesome. All right, thank you for having me. I love talking about this topic. So I want this presentation to be as interactive as possible. So please do get out your cell phones. There will be some interaction on our audience response system. So as much as you can, try to stay off Instagram, but we will have interaction that way. I'm also monitoring the chat as well. So if you have a question that I can answer, I will stop and answer it. Or if we can address them at the end as well. So whatever you guys are comfortable with. This Safe Home, or the Safe Home Opioid Management Education in Older Adults program, is also HRSA funded through Rush University and UIC through the Catch-On HRSA Geriatric Workforce Enhancement Program and the E4 Center of Excellence for Behavioral Health Disparities in Aging. So welcome, everybody. We'll get started. The first thing that I hope you'll be able to do is take a baseline survey. This is just to obviously get a baseline of what your knowledge on opioids and naloxone are. If you want to scan this QR code, or I will also put the link in the chat. Talk and type at the same time here. I'll put the link in the chat, and it's a 10 true, false, or I don't know statements. So I'll give you a couple moments to complete that. Hope that worked. So it is currently my time, 11:05. I'll give until about 11:08, and then we'll jump back in. It will ask you the date that you are attending this presentation. Today's date is February 8th of 2023. So if you're watching the recording and also doing the survey, please put February 8th of 23. Right, it is currently 11:08. If you are still working on the survey, please complete it. The next couple slides are background slides, so probably nothing that you guys don't know. So please complete the full survey and we'll jump back into it later. We already went through the learning objectives, but today we're going to discuss the risks associated with opioid use, particularly in older adults. We'll describe how to recognize an opioid-related overdose and explain how to access and use naloxone for the reversal of opioid overdose. And at the end, we'll kind of go over the Safe Home program and what we've been doing to expand this education across my state and across the US. So just to give a brief background on the opioid epidemic, I'm sure you guys have heard of it because you are joining this webinar. But what I want to do is kind of gauge your understanding and your opinion. So what I want you to do is I will put this link in the chat. Or I can also click on this QR code here if you'd rather scan that. But this will allow you to join the audience response system, and then you can answer the polls. So let me put this in the chat here. Great, we have some people joining. Please let me know if you need me to bring up that QR code again. But these are some of the words that you guys are inputting of what comes to mind when you hear the phrase opioid opioid epidemic. So I see fentanyl, lots of usage, prescribing, big problem, despair, widespread, deaths. These are all great words to describe it, I think. Particularly widespread, severe. I love this. So the words that are getting bigger are the ones that are being repeated from the people in the session. Great, I think these are all great words that I think most of us would associate with the opioid epidemic, so thank you. All right, let's go into specifics here. So as of 2022, about 187 people die every day in the US from an opioid overdose, and that includes both prescription and illicit opioids. If we look at overdose deaths in the US, more than 930,000 people have died since 1999 from a drug overdose. And in 2020, about 92,000 drug overdose deaths occurred, and 68,000 were opioid related. About 22% of those were adults over the age of 55 years old. And we do know that these numbers are increasing over time. If we look at the 12 months from April of 2020 to April of 2021, so basically when COVID first hit, the drug overdose deaths in the US did reach 6 figures. So another response question, you can click the link in the chat, or I'll also bring up the QR code again. But which of the following opioids do you think contributes to the most overdose deaths in the US? If you need that code again, I'll bring it up. But we have A for heroin, B for oxycodone, C for methadone, and D for fentanyl. Is our QR code, just in case you needed it again. Our results here. So majority of us think fentanyl, some of us think oxycodone, and some of us think heroin. I will say this is kind of a trick question because it depends on what time in history you're looking at. So if we look at the overdose epidemic in the US, there really were 3 waves in the rise of overdose deaths. The first one happened in 1999, which kind of started with the over-marketing and prescribing of opioids in the 90s. There was a little attention to safety and the habit-forming potential of opioids. And this resulted in a large increase in the incidence of overdose, the incidence of addiction and dependence. Now, once the safety risks and the habit-forming potential were recognized, there was kind of this reactionary crackdown on opioid prescribing in the US. So this led to patients seeking illicit opioids because we prescribed opioids for them. They became dependent, but now they can't get their prescribed opioid anymore. So the next wave happened in about 2010 with the rise in deaths related to heroin. And then in 2013, there was a rise in synthetic opioid overdose deaths. So it really remains, the prevalence of opioid overdose and opioid use disorder remains significant today, despite all of the various management efforts that we've been implementing here. Looking specifically at prescription opioids, if we look from about the same time frame, 1999 to 2020, the overdose deaths that involved a prescription opioid increased more than 5 times in that time span. And that totaled nearly 263,000 people. That includes 24% of all the overdose deaths involved a prescription opioid in 2020. And that also equates to about 44 people dying every day from an overdose involving a prescription opioid in 2020. Overall, from 2019 to 2020, the prescription opioid overdose deaths increased by 17%. So From 1999 to 2020 seems like 5 times increase. That was just 1 year that they increased by 17%. So I want to do a true or false, fact or fiction. Let me know, do you think the statement's true or false? Someone can still overdose even if they follow the directions on their opioid prescription. Some answers in the chat, and we also have some on the screen here, so I love it. Everybody is on the same page here that this statement is true. Someone can still overdose even if they follow the directions on the opioid prescription. And that can be due to a lot of different reasons, whether it be the other medications that they're taking or some of their co-occurring diseases that they have. So let's zoom in. That was kind of overall opioid overdose deaths in the US. But let's look specifically in older adults. Now, this study showed was from 1999 again to 2019, looking at the opioid overdose death rate in people 55 years and older. So while this population is a small percentage of the overall opioid overdose deaths, we know that the rate of death in this population is still increasing pretty markedly. So let's look at why that happens. As we age, we are more likely to be prescribed long-term opioids for chronic pain. Not only are we more likely to experience chronic pain in general, but we know that an older adult is more likely to be prescribed a long-term opioid for that pain than someone who is younger than them. We're also more likely to take other medications that can interact with opioids. That could be things like gabapentin and pregabalin or Lyrica, Z drugs, which can help with sleep, and muscle relaxers. So those all interact with opioids and increase our likelihood of overdosing. We also are more likely to have comorbidities or co-occurring disease states that increase our overdose risk. So those can be things like dementia. So if someone takes their opioid and then they had forgotten that they took it, and so they took it again, that could increase their overdose risk. And then things like sleep apnea, COPD, and other lung diseases, those also increase our overdose risk based on the mechanism of how overdose happens. And we'll get into that in just a second. As we age, again, we are also more likely to experience worse opioid side effects. So this can be due to a variety of reasons, but we know that older adults experience constipation more than younger people, more sleepiness, depression, more falls, and then of course, death. So that is a lot of reasons that our older adults are at a higher risk than younger patients of overdose. So let's look at specifically how this happens. In our brain, we have 3 different opioid receptors. They're mu, delta, and kappa. The opioid has specific affinity, or it binds to these mu receptors the most, and those deal with mediating pain specifically. So as we increase the amount of opioids in our system, overall, we're going to slow down our central nervous system. And what that results in is really, it slows down the brain's drive to breathe. It reduces our level of consciousness, and it also slows down our heart rate. So the number one thing that is really the main lethal outcome of too much opioids in the system would be this slowing of the respiratory drive, or the brain's drive to breathe. So that is really what causes the overdose and the death to happen. So let's say we find someone who's unconscious on the street, or on the train or public transit or what have you, how can we tell if someone is overdosing specifically from an opioid? These are all the things that we can look for. So number one, we're going to look for blue lips or fingernails, and we know that that's based on not having enough oxygen because we're not breathing, or our breathing is not fast enough to deliver the oxygen to our tissues. Again, we're also probably going to monitor that person's slowed or stopped breathing. They're going to be unconscious or unresponsive to you, no matter how much you shake them, do a sternal rub. They're likely going to be pale and have some clammy skin. And like I mentioned before, their heartbeat or their heart rate will be slowed, and they'll have low blood pressure. Now, all of those things aren't necessarily specifically or specific to an opioid overdose. The one thing that is a telltale sign of an opioid overdose would be these pinpoint pupils. So we can tell, if we look in their eyes and their pupils are very, very small, likely they are overdosing from an opioid. So those are all some scary things to talk about, but I want to talk about this term harm reduction. And before we get into it, I want to hear what you guys think, what words come to mind when you hear the phrase harm reduction. If you need the QR code, it is there, and I will also put in the code in the chat here. Right, so in the chat, we have safe using, do the least harm, preventing catastrophic results. I love those answers. Lots of answers on our word cloud here. So it looks like we have decreased use, polypharmacy, methadone. Looks like some needle programs. Prevention is a great one. Better safety, literacy, all great answers. Let's get into the principles of harm reduction. What does this mean? So first, we're going to recognize that drug use is complex and multifaceted, and drug-related harm is affected by social inequities. We're also going to prioritize the quality of life of a patient who is using substances over cessation of drug use. So this is kind of a shift in our thought process, where before, abstinence was the main goal of recovery, whereas this is where prioritizing their quality of life over the cessation of all of their drug use. In doing so, we're minimizing the harmful effects of drug use rather than ignoring or condemning these patients. And we're going to provide non-judgmental, non-coercive services. In doing so, we also empower the people who use drugs to be the primary agents of reducing their harms. And to do this, we're going to ensure that people who use drugs have a voice in the programs and policies that serve them. Now, that can be pretty abstract. Let's get into some actual examples of what this means in practice. So we mentioned on the word cloud, I saw some needle exchange words. So needle exchange programs are a way of providing the opportunity to use safely and minimizing the transmission of infectious disease. Safe consumption sites are similar. They are a place that someone can go to use a substance and be medically monitored. So in case they were to overdose or something were to happen, they were in a safe space. Safe substance disposal is also a big one. The DEA has annual drug take-back days to minimize the amount of opioids on the street. We're also going to refer people to treatment. So as a healthcare provider, if we're recognizing someone might have an issue with substance use, we will refer them to treatment versus just letting them go. And what we're going to talk about today is accessing naloxone. Let's get into what naloxone actually is and what it looks like, how it works. So if we look at this figure here, we have the opioid receptor, probably the mu receptor, right? That is the cone-shaped figure in the middle of the slide. And we have our opioid that's attached to that receptor and potentially causing an overdose. The naloxone comes in, and let's say we recognize someone on the street or one of our patients or whoever. We recognize that this person is overdosing from an opioid, and we administer naloxone. The naloxone is going to come in and kick the opioid out of its binding from the opioid receptor, and it will completely but temporarily reverse the overdose. Now, once the naloxone is bound, it has much higher binding than the actual opioid. So if the opioid is still floating around, it will actually block it from reattaching. Now, I did mention it completely reverses an overdose, but it is temporary. So naloxone only lasts 20 to 30 minutes, depending on how we administer it. So if someone were to be overdosing on a long-acting opioid, let's say an extended release prescription opioid, when the naloxone goes away and is cleared from the body, we might have opioids still in the system. So if that were to happen, the overdose can actually happen again. We have to give naloxone again. So it's really important that when we give naloxone to somebody that we get them medical attention in case that were to happen. So we'll go through a couple fact or fiction, true or falses, specifically related to naloxone. So what do you think? Naloxone can harm someone who does not have opioids in their system. We're not as unanimous as before. I like it. So we have a factor, about 30% of us think fact, about 70% of us think fiction. So this is actually false. Naloxone cannot harm somebody who does not have opioids in their system. And there are a couple different formulations of naloxone that we'll go over. Really the only harm would be if you, for example, if you were to give an injection, they might have an injection site reaction, just like any other injection or any other drug that you might give by injection. If you use the nasal spray, you might have some nasal irritation, and that's really about it. So if you think of how the mechanism of naloxone, we have this opioid receptor with the opioid bound to it. If you don't have opioids in your system, that opioid receptor is empty, the naloxone is going to bind to it, and nothing's going to happen. There's really no side effects if someone does not have opioids in their system. Looking specifically at the naloxone formulations, we'll kind of go in order of how they were released or approved, marketed. The first formulation was this vial and syringe. It, again, is a syringe that you would draw up the dose and then give it by intramuscular injection or into the muscle. Now, if you think about someone who maybe is a healthcare provider but doesn't like needles, or someone who's not a healthcare provider, trying to give naloxone to potentially a family member, a close friend who's overdosing, and you're not exactly confident with giving an injection, this can be pretty scary, and you might fumble, you've got adrenaline pumping. So it is it does require that assembly, but it is not, but it is the cheapest of all the formulations. So that is one thing to consider. There's a little bit of a give and take. Next came out this atomizer. So we have this nasal spray, but it does still require assembly before we administer it to somebody. So you can see that cone-shaped item there. That is the part that actually goes into the nose and provides the nasal spray. Now, again, that does require a bit of time. You're probably going to fumble around if you're trying to do it quickly, which is why they came out with the Narcan nasal spray, which is probably the most widely recognized formulation of naloxone. So it does come in this nasal spray. It's a once and done nasal spray. There are 2 of these pumps in each box. So if you go to a pharmacy or what have you, they will give you 1 box with 2 doses in it. And just for completeness sake, we also have the Evzio, which is an auto injector. So it can be administered through the clothing. When you open that white cap, it actually will talk you through how to give the naloxone to someone, and you actually don't see the needle. So if someone had a fear of needles, this would be something that potentially could be useful for them. Now, I've included it for completeness sake because it has been discontinued on the market, and that's really because it was just so expensive compared to the other formulations of naloxone. But I include it because it was recently discontinued, so if you might find it, you might find it in a patient's medicine cabinet or whatever. I was on the mobile unit the other day, and we were responding to an overdose, and a bystander was like, "Yeah, I just gave them this," and they pulled out the Evzio. I was like, "Wow, that's the first time I've ever seen that." So I just wanted to let you guys know that that is a formulation that is floating around out there. So let's walk through what you would actually do in the event of an opioid overdose. So number 1, we're going to check the person's responsiveness. If they are awake and talking, likely they're not going to need naloxone. Likely we're responding to them because they are unresponsive or unconscious. So we check their responsiveness. We recognize that they might be overdosing from an opioid. We say, okay, I'm going to respond to this. Number 1, we're going to call 911. And that is because, like I mentioned before, the person's probably going to need medical attention after you give the naloxone. So we want to give them time to get to your location, wherever you are. We're also going to give the naloxone. Now, it's important to note that a patient may need more than 1 dose, which is why they give you more than 1 dose in those boxes. And we're going to listen to the 911 dispatcher and provide rescue breaths and chest compressions as they instruct you. So they will help you through that if they think that that is something that should be provided to that patient. Now, overall, if nothing else, let's say we give naloxone, we call 911, number 1 thing is we want to stay until help arrives, because we likely don't know what this person is overdosing on, and they might re-overdose, like I mentioned before. So we just want to make sure that they're okay until other help comes to aid them. Let's jump back into our fact or fiction. What do you guys think? I can only get naloxone if I have a prescription from my doctor. Got some A's, we've got some B's in the screen. We got a couple B's in the chat. Is great. So we do, the answer is false. you do not have to have a prescription from your doctor to access naloxone. One way that we can access naloxone is through a standing order. Now that is one prescription order that can be used for a large group of people. So if you think about, for example, you want to get your flu shot, you're going to walk into your pharmacy, you're going to go up to the pharmacist, and you're going to sign up for a flu shot. That is because there are standing orders for the influenza vaccine. So the pharmacist can input a prescription via that standing order and give you the flu shot. It is the exact same for naloxone at a pharmacy. And so if you look at a traditional prescription, we have an illness or, I want to get this medication. So we'll go to our doctor. They will then send us a prescription to the pharmacy, and then we get that medication. The standing order kind of skips that step, and you go straight to the pharmacy and get your medication. Now, the availability of standing orders do vary by state. So if you look at the availability of standing orders across the US, the states in blue, which is a majority of the US, have a statewide standing order in place. The states in red, the standing order is allowed, but no standing order is in place. So it's allowed by law, but there's not necessarily a standing order in place. The states in green have pharmacist prescriptive authority. So let's say if you're in Oregon, you can go up to the pharmacy and they can prescribe you naloxone versus using the standing order. And then states like Oklahoma or Puerto Rico have some other direct authority by some statute or administrative order that doesn't include the pharmacist or the standing order. So potentially for the states in red, that's an area of advocacy, but it is good news that across the US, statewide standing orders are allowed, at least in these states. All right, let's go to our next true or false. My insurance will not cover naloxone if I do not have a prescription. Do you think that's true or false? We're split again. So this is false, depending on your state. So there's always an asterisk at the end of these answers. So if you look at the insurer requirements for naloxone, we see a lot of gray on this map, which means it's really not addressed. So again, an area of advocacy for those states. The states in blue, there's a requirement on health insurers that they have to include at least one formulation of naloxone on the lowest tier of their formulary. That doesn't mean it's going to be the nasal spray, and it doesn't mean that it'll be free. That means that at their lowest tier, regardless of what that copay is, they have to include at least one formulation. Now, the states in red have a requirement on life insurers. So that means that if you sign up for life insurance and they see that you've been dispensed naloxone before, they can't deny you life insurance. And then the states in green have both. And again, the states in gray they don't address the insurer requirements for naloxone. All right, one more. I can get arrested or fined for giving naloxone to someone I don't know. This is also split, it looks like. So this is false, depending on your state. A lot of people, the common term for this is layperson immunity or Good Samaritan laws. So the states in red have civil immunity only, and that means that another person can't sue you for giving naloxone to somebody. The states in green the state cannot arrest you or fine you for giving naloxone. And then the states in blue have both. And then looks like South Dakota, looks like that's the only one, is the one that doesn't address this at all in their laws. So again, potentially areas of advocacy for green, red, and gray states here. All right, true or false, increasing access to naloxone will only enable people who use drugs to use more. What do you guys think? Looks like we've got some B's in the chat, also B's on the slide. A question in the chat, does the immunity cover medical personnel not acting in their professional capacity? I think I would have to refer to a specific state to understand that, to more completely answer that question. So I would refer you to that state law as well. We do have a couple of studies that have evaluated whether increasing the access to naloxone within the community increases drug overdose death, and in that case, drug use. So in one study in 2018, found that states with naloxone access laws and these Good Samaritan laws, or layperson immunity laws, had about a 14% decrease in opioid-related mortality between 2000 and 2014. And they estimated that in areas with high distribution naloxone programs, so lots of institutions or pharmacies or departments of public health distributing naloxone in the community, that could have increased to about 20%. There really is no evidence that enabling easier access to naloxone increases opioid use in the community. Now, there is another way to access naloxone, and that is through a prescription. Your doctor can still send a prescription for you. And there is a concept called co-prescribing, which means that the physician will, or prescriber, will prescribe naloxone along with the prescription for the opioid. And in one study, this found that there were about 63% fewer emergency department visits within 1 year of implementing this co-prescribing. And the patients who got that co-prescription kind of felt an increased sense of security after receiving that naloxone prescription. So if you think about with prescription opioids in particular, and if we think about our older adults, a lot of them live in multi-generational homes where they have grandchildren, friends, family, caregivers who might be able to access their opioids and potentially accidentally overdose. So that's one reason I think this kind of applies, is that these patients just felt more secure having this this tool in their house. Now, requirements for co-prescribing does differ by state. So if we look at the blue states, prescribers must co-prescribe naloxone with an opioid. So that varies state to state, whether that means every opioid prescription, whether that means an opioid prescription that meets a certain day supply. That does vary state by state, but these are the states that do require a co-prescription. In red states, prescribers may co-prescribe, and in green states, the prescriber must notify the patient about naloxone and its availability, but they are not required to co-prescribe it. And then gray is that it's not addressed. So again, lots of areas of opportunity to advocate for our patients. So what's this problem? We have this opioid epidemic that is affecting older adults. We also have this life-saving medication, but there's still increasing overdose deaths in this country. So what's the deal? Where's the gap? We do know that older adults taking opioids most of them generally are unaware of their risks and or they don't know how to access naloxone. So this is where we came in as in the Safe Home program, is to spread this education to older adults where they are. So what we did was we targeted care coordinators or home health workers and provided education for them to then go out into the community, into a community dwelling older adults home and talk to their clients about their opioid risks. Now, when we're talking to an older adult, I just have some strategies here in case you were to want to provide this kind of information. So we want to avoid medical jargon. We want to sit face to face. We want to allow time for questions. And in general, just check their understanding throughout the conversation. We did, through this program, work with our colleagues at Rush University who have expertise in training healthcare providers to be a part of the geriatric workforce. And together we kind of determined the methods to deliver this education. So we used all this information to create an older adult-friendly opioid and naloxone toolkit to help us with that education. So the first one is a front and back handout related to the risks of opioids. These have been vetted for the appropriate reading levels for older adults, as well as fonts, text sizes, and colors for someone who might have reduced visual acuity. And then the second one is related to naloxone, both how to get it and how to use it and why it might be important for somebody who's using a long-term opioid to access. So really what we're trying to do with this expansion of this education for the older adult is putting the patient at the center of the interprofessional healthcare team. So I put the patient at the center here with their primary care provider, me as the pharmacist, going to interact with social workers, nurses, dentists, physical therapists, psychiatrists, and we're also engaging these home health workers that interact with the patient weekly, sometimes daily. And so when I talk about home health workers, lots of different agencies and institutions have different names for them. So I'm mentioning home health workers. Some people call them care coordinators, patient navigators. You might have your own name for this type of role, but they might be trained as social workers, nurses, a licensed counselor, etc. And really they're providing services like assisting with tasks related to the medical and social needs of the patient. And they're liaising between the patient or the older adult and their provider. So we really saw them as an opportunity to engage the older adults as well. Now, let's talk about what we actually did for these patients. So I mentioned we did target home health workers, and they then gave the education to older adults. They, during this education, they had the older adults take the survey that you took at the beginning of this presentation, these 10 true or false questions. And then we compared the scores before the education and after the education. So I just want to share those results with you guys here. You'll probably recognize these statements. Here's the baseline knowledge score. So if we look at the first 4 questions, you'll probably recognize are related to opioid risks. In general, it's pretty low scores, but it's at least higher than these naloxone scores. There's really a gap in what a person knew about naloxone. Now, if we look at our matched pre and post-education knowledge scores, the overall score before the education was 39.4%, and then after it increased to 90.6. So that was great news that we're at least increasing their knowledge on their risks of taking an opioid and how we can expand access to the life-saving medication. We also wanted to look at the home health worker knowledge. Like, we're providing this education to the home health workers who are then passing along that information to older adults. So we want to see if we're having any effect on the home health worker knowledge. So if we look at these opioid questions, you can see they're in the like 80s and 90s, which is much higher than that baseline older adult score. But again, these naloxone scores are lower, at least than the opioid knowledge. So we gave us this education and then did the post-education survey, and those scores are here. So we do see an increase across each of these statements as to how many of the home health workers got them correct. And this is just showing that increase pre and post education for the total knowledge assessment. And then the middle is the opioid knowledge, and the right is only the naloxone knowledge. So the middle column is questions 1 through 4, and naloxone is questions 5 through 10. And we can see that the increase in the total score is really driven by the increase in the naloxone knowledge. We didn't really have an effect on the opioid knowledge, and this is really because the baseline knowledge on opioids and their risk was already pretty high. So again, I hope that you got something out of this and that your score will increase after this educational session. So if you could, you'll take the post-education survey. You can scan the QR code now, or I'll put this in the chat here. And that kind of concludes my portion. I would love to hear your questions and comments.
Thank you very much, Dr. Elmes. And thank you everyone for being here with us today. I am going to give everybody a couple minutes to fill out the post-evaluation survey, including myself. And if you have questions, please put them in the chat. I know there was one comment, Dr. Elmes, about what do Good Samaritan laws cover? And I know that that's going to vary from state to state, but I think it's especially tricky when you're a healthcare provider and worried about licensing and consequences from being a Good Samaritan. Can you comment on that at all?
Yeah, again, it will vary state to state. I think I'm catching up on the chat now. I think Denise and Laura make good points of like whether that would meet gross negligence, would a professional be liable? And again, that might be a question for the institution that you work for, or maybe even just consulting those laws. Yeah, I can't really comment more specific than that.
Thank you. Are there other questions? I'm still working on my survey. All right, I'll stop looking at my phone. Done with my survey. So I do have copies of slides for everyone. I will email them out following the presentation. Abigail, I did get a comment from a couple people about the handouts for some of your patients. Is it possible for you to send me a PDF of those, or is there a website where we can download those?
Of course, I can send them to you to distribute.
That would be wonderful. Those were very, very nice handouts and looked very clear and understandable for our patient population. I do see a question about CME credits. So I have been taking attendance throughout the session. I have to compile that, send that over to our CEL office. They upload it within usually about a week of when I send it to them. So then you'll see it hopefully in about a week, but we tell people not to check before 30 days because sometimes they get backlogged. So within 30 days, you should see evidence of your CME credit or social work credits in your profile in your online portal. And if you haven't made a portal before or made a profile in the portal before, I will send you instructions to do that as well. So I think because we have a couple extra minutes, I will put the evaluation survey link in the chat. If folks want to take the evaluation survey, we'd appreciate your feedback. I know I love the interactive nature of this presentation, as well as the good information that you provide and the evidence for providing supports to older adults at home. I think it's just a fantastic program. So you should be very proud of what you've done and the difference you've made for the older folks in the program.
Thank you. I'll put my email in the chat just in case anybody has any questions or comments or ways to improve. That would be also very appreciative.
Okay. All right. So I'm going to say if there's no further questions, everyone can have an extra 4 minutes back for your day. We appreciate your time so much. We do have another presentation scheduled next month with Cheryl Martin from CCSI in Rochester, and she'll be talking about motivational interviewing and trauma as one of the causes for the opioid epidemic in older adults. So we hope you'll join us for that. And everyone have a wonderful day, and we'll see you next month. And thank you again, Dr. Elmes.
Thank you, Dr.
Thank
Elmes.
you.
Okay, bye.